So now we will continue with video 2, that is asthma. So when we say asthma is a condition of the lungs in which there is an airway obstruction due to spasm of the bronchial smooth muscle. So the bronchial smooth muscle, there is a spasm and edema of the mucosa and increased mucus secretions in the bronchi and bronchioles brought on the various stimuli. Okay, so it is the obstruction that happens because of the spasm of the bronchial smooth muscle. You can see that in the diagram that is given down. So it is a chronic inflammatory disorder of the airways in which cells play a role. In susceptible children, inflammation causes recurrent episode of breathlessness, wheezing, chest tightness and cough, especially at night or in the early morning. So because of the spasm, okay, we can see the symptoms that is there in the child. Okay, so asthma is a chronic. So when we say asthma, it is a chronic inflammatory disorder of the airway in which many cells are involved in it and they play a role. So in children when they are affected, this inflammation causes recurrent episode of wheezing, breathlessness, chest tightness, cough, and especially at night or in the early morning. Okay, so next we will see what are the etiological factors. So when you say etiological factors, the allergy to pollen, food and antigen, antibody reaction, infection. Okay, physical factors like cold, humidity, sudden change in temperature and sudden change in barometric pressure. So irritants such as dust, chemicals and air pollution. Psychological or emotional stress, exercise. Okay, so these are the various factors that can lead to asthma in the child. Okay, so those are the causative factors. Okay, next we will move on to clinical manifestation. So we will see what are the various clinical manifestation. So the onset may be gradual with nasal congestion and sneezing. So when we say onset, it is actually very slow and it first starts with nasal congestion and sneezing will be found. So the attack may be sudden, generally at night. So all of a sudden the child will develop this condition in the night. So wheezing with the expirations, anxiety, apprehension, diaphoresis and uncontrollable cough is present. The attack may be controlled by the treatment. So through the treatment this sudden attack can be controlled. So when we see, okay, when they are inspiration and expiration, during expiration you will hear the wheeze sound. So what is wheeze? We have studied in the first year, musical whistling sound, right? And anxiety will be there, apprehension, again anxiousness, diaphoresis, profuse sweating and uncontrollable cough also is present. Okay, so it can be controlled through the treatment when it is given. Sometimes attack may progress and develop increased dyspnea, thick tenacious mucus, coarse rales, flaring of the nostril. So these all you can see that the child will be suffering with dyspnea and the sputum will be actually very thick. Okay, then rale sound will be there. Okay, and then flaring of the nostril. Use of the accessory muscles of the respiration, that is the sternocleido muscle will be used when the child is trying to respire. And then cyanosis, you know what is cyanosis? Bluish discoloration, that is because of the less of oxygen. Hypercapnia, increased level of carbon dioxide, then increased pulse and increased respiratory rate, vomiting and anxiety. So all these are the clinical manifestation that is found in the child. Now coming on to the investigation. So eosinophil, as you know, ESR count has to be taken in the peripheral blood, then examination of nasal secretions and sputum has to be done. Okay, and then polymorphonuclear leukocytosis in the presence of infection. Okay, so that test has to be done. Pulmonary function studies like X-ray, okay, is required. Chest X-ray is required. Apart from that, functioning of the lungs has to be done, where we will check the breathing capacity, how much a person, the child is able to breathe or an individual is able to breathe. Then tidal volume, the amount of air that is taken, amount of air that is found at rest. Okay, usually it is 500 ml, so that has to be checked, and forced expiratory volume. Okay, then blood gas has to be analyzed and pH value has to be checked. Okay, so we will see if there is infection, then we will see that there will be polymorphonuclear leukocytosis. Okay, so these are all the various investigations that has to be done. So going on to the treatment, the suspected stimulus should be removed such as allergen, irritants, exercise and emotional factors. So sometimes because of anxiety, apprehension also they can develop, so that has to be identified, rectified. Any allergen, irritants, keep the patient from the allergens and ask them to do exercise. Usually for asthma they say swimming helps, jogging helps. So we can also tell them to do certain kind of jogging by which the child will be able to overcome asthma. Jogging also is a very good exercise. So then desensitization to build up resistance to these allergens. So desensitizing, inhalers can be given or certain antihistamines can be given so that they will be desensitized to the allergen. Then symptomatic drug therapy, that we know according to the symptoms it has to be treated, prescribed such as bronchodilators. And then supportive treatment should be provided such as adequate fluid intake, adequate oxygen treatment of infection and correction of acid-base balance. Next, coming on to nursing management. So what do we do? Observe the patient condition, then severity of the attack and degree of respiratory distress should be observed. And then breathing pattern should be noted for expiratory dyspnea. Then it should be observed whether the patient use their accessory respiratory muscle and have nasal flaring. Check as a nursing management, first check the vital signs, see if there are any signs of grunting, and then abnormal sounds that is present, wheeze, or then you can see if there is any nasal flaring, use of accessory muscles like abdominal muscle or sternocleido muscle, you have to check. And then the level of children anxiety should be noted. Then the patient should be observed for cyanosis. If patient are at sleep, they should not be disturbed until it is necessary. And then reassurance should be given that you will be all well, don't worry, to reduce the anxiety. Then dehydration should be treated by providing adequate fluids. The normal diet can be started when the patient can take it. Proper breathing habits should be encouraged such as abdominal breathing, side expansion breathing, forward breathing and elbow arching. So all this habits has to be taught to them and make sure that they are doing it. Now coming to complication, it can be bronchiectasis, emphysema, car pulmonale. So these are the three complications that the child can develop because of asthma. And then you have parents should be advised about development of healthy habits in their children. Children should be provided balanced diet, allergens should be avoided, the regular follow-up should be attended. So now this are all the conditions which you have already studied in your medical surgical nursing. That's why I am just reading and self-explanatory. So you should be knowing all these conditions. So next we will go on to pneumonia. When we say pneumonia, it is an inflammation of the pulmonary parenchyma and it is common in childhood but occurs more frequently in infancy and early childhood. So when we see the types, there are 5 types: lobar pneumonia, bronchopneumonia, interstitial pneumonia, viral pneumonia and primary typical pneumonia. So we will see what it is. So when we say lobar, all or a large segment of one or more pulmonary lobes are involved. When both lungs are affected, it is known as bilateral or double pneumonia. So when both, it can be a part of the lung or a large part of the lobe of the lung which is involved, and then both the lungs will be affected, it can be called as bilateral or it can be called as double pneumonia. Then bronchopneumonia. When we say bronchopneumonia, it begins in the terminal bronchioles which become clogged with mucopurulent exudates to form consolidated patches in nearby lobules, also called lobular pneumonia. So it actually starts with bronchioles, where you have mucopurulent discharges, exudates will be formed, thick secretion in the bronchioles will be formed. Later it will become like consolidated patches, hard patches on the nearby lobules of the lungs. So it is also called as lobular pneumonia. And then you have interstitial pneumonia. The inflammatory process is more or less confined with the alveolar walls and the peribronchial and interlobar tissue. So when you are studying these types of pneumonia, you should know which part of the lungs are affected. So inflammatory process is more or less confined with the alveolar walls are getting affected, and then the peribronchial and interlobular tissues are getting affected. So that's why we call that to be interstitial pneumonia. And then you have viral pneumonia. So here Viral pneumonia, which occur more frequently than bacterial pneumonia, are seen in children of all ages and are associated with viral upper respiratory tract infections. So when it is affected because of virus, then we call that to be viral pneumonia. So viruses that cause pneumonia include RSV in infants, and then you have para-influenza, influenza and adenovirus in older children. These are few clinical symptoms that are unique to a specific virus, and the differentiation among viruses is usually made by laboratory examination. Okay, so you also have other conditions like RSV in infants and para-influenza, okay, or adenovirus in older children. So clinical symptoms, they vary according to the virus, and it can be identified. How it can be identified which virus is affected? Through the laboratory blood test. Now coming to the last one, that is the primary or atypical pneumonia. So Mycoplasma pneumoniae is the most common cause of pneumonia in children between ages 5 and 12 years. It occurs in the winter months and is more prevalent in crowded living condition. So this is mostly found in a crowded condition where the age group of 5 and 12 years of children are affected. Most affected person, they recover from acute illnesses within 7 to 10 days with symptomatic treatment followed by a week of convalescence. Hospitalization is rarely necessary. So it affects mostly with the age group of 5 and 12 years, and we see the treatment will be given, okay, for 7 to 10 days, and then the child will be treated. Okay, so these are all the 5 types of pneumonia. Next, coming to signs and symptoms of pneumonia. So general signs of pneumonia, when you see fever, usually quite high respiratory. So cough will be there. So you know it is unproductive to productive to whitish sputum. Tachypnea will be there. Breath sounds rhonchi. Okay, rhonchi will be there. Fine crackles sound, abnormal respiratory sound you can hear. And then dullness will be there with percussion. When you percuss the lungs, you will feel dull, and then you will have, the patient will have chest pain, retractions, nasal flaring, pallor or cyanosis. Behavior will be restless. You know, the child will be lethargic. Then gastrointestinal symptoms, anorexia, vomiting, diarrhea, abdominal pain, the child will be having. Talking about the diagnosis, chest x-ray and complete blood count has to be done. So talking about medical management, as usual, antibiotic, bronchodilators, if required corticosteroids can be given, oxygen therapy, chest physiotherapy, then steam inhalation can be given, and then nebulization. All this can be included. Okay, so with this, along with nursing management, you should be able to do for this kind. And we also have another type, okay, that is the last type, which is the bacterial pneumonia. So we have viral, so here you also have bacterial pneumonia. So Streptococcus pneumonia is the most common bacterial pathogen responsible for community acquired pneumonia in both children and adults. So bacterial pneumonia can affect both children as well as the adults, and then during the last several decades, it isolates a Staphylococci pneumonia organism that are resistant to penicillin, and other antibiotics have become more prevalent. Other bacteria that causes pneumonia in children are group A Streptococcus, Staphylococcus, Mycobacterium aureus, Catarrhalis and Haemophilus influenza. So these are the few examples which you should know which causes the bacterial infection. So beyond the neonatal period, bacterial pneumonias display distinct clinical patterns that facilitate their differentiation from other forms of pneumonia. The onset of illness is sudden, abrupt, and generally follow a viral infection that disturbs the natural defense mechanism of the upper respiratory tract. So once if they are affected with bacterial, automatically it also paves a way for viral infection. So complications, when we see, it is emphysema, okay, okay, pus collection, and then pneumothorax, okay, air collection in the lungs or tension pneumothorax, necrosis, death of the tissue, meningitis, inflammation of the meninges, abscess, pus collection. Okay, and then you have nursing management with pneumonia. So talking about the nursing management, again, assess sign for respiratory distress, check the vital signs, monitor child for respiratory rate, what is the pattern, any abnormal breath sound, so auscultate and see, maintain patent airway, see if there is any obstruction, check if the baby is able to breathe properly, you have to administer oxygen, provide semi-Fowler's position, You know why we should give Fowler's position? Because the abdominal organs, due to the gravity, is pulled down, the vertical diameter of the lungs increases, thereby the child will be able to breathe normally. Then change position very frequently. Prepare child for chest drainage. Provide adequate rest. Provide adequate fluid. Then maintain intake and output chart. Then provide toys depending on age. So play is an important factor we should consider, and we have to provide play as per the age group. So we have done with respiratory conditions. Okay, next class we will start with GI system.